So good evening, and thank you for joining us tonight for our latest webinar from the East Sussex Eye Group. This webinar will be recorded, and I've been told we can put it onto the East Sussex Eye Group YouTube channel, so you can view it afterwards if you wish to. There is one CPD point available for tonight's lecture, and that's if you're watching it live from the link when you registered and you entered your details. And the CPD point is available for optometrists and dispensing opticians. The lecture will run for approximately 45 minutes with about 15 minutes at the end for questions. So there is a Q&A box at the bottom of your screen. So if you have any questions during the webinar, please post them there. And at the end, I will then present them to our speaker tonight, Mr Kashani. So I would like to welcome tonight's speaker, Mr Shahram Kashani. He's an ophthalmic consultant surgeon at East Sussex Healthcare Trust, specialising in the management of complex medical retina disorders. He performs intravitreal anti-VEGF injections, steroid implants, anterior and posterior laser segment treatments, as well as high-volume cataract surgeries. He's previously been the clinical lead for East Sussex NHS Trust and is now the head of retinal services and uveitis. Tonight, he will present to us a lecture on the swollen disc, assessment and management with a focus on vascular causes. So I will now hand over to you, Mr. Kashani. Thank you very much.
Thank you, Ian. So I'm just going to share uh, my screen. Is that working, Ian? You can maybe text me because I know you can't.
Yes, that's working.
Okay, thank you very much. Cheers. Okay, well, happy Christmas and happy New Year to everyone. This is our first one. I'm sorry we were a little bit late with this one, but we certainly are planning to continue with our kind of monthly talks. So rest assured that Ian is on my case and I'm on his case in order to make sure this happens. So today we're going to kind of talk about the swollen disc actually. Um, okay. So what I'm going to talk about is just symptoms, what you might see on examination, what a normal disc looks like, pathological cases. We're not going to do congenital cases because that was done before. Your approach to an abnormal disc, and then kind of I've written final thoughts, but actually we have a quiz at the end. So Ian will be putting the poll up, and you will be asked a few questions. So when we're looking at symptoms from an optic nerve, first of all, it's very important to say that in majority of patients there might not be any. And an example of that is patients, for example, with primary open-angle glaucoma, where they present to opticians, as you know, without any symptoms, and yet they might have quite profound visual field defects. Some conditions like optic neuritis, you might actually have pain in the eye, especially on eye movement, and that's because as the eye moves, the nerve sheath that's inflamed will be painful. Of course, the ischemic optic neuropathy, which we are going to kind of talk about a fair amount during this talk, if there is pain associated with that, inflammation of the blood vessels, can give you painful loss of vision. And then, others, I guess no one will come and tell you they've got reduced contrast, but color vision is something that tends to go in patients with optic neuropathy, more so in non-glaucomatous patients. So often that's a good way of determining if somebody has, optic nerve disease from inflammation, infection, compression, as opposed to glaucoma, because in glaucoma, the color vision is often preserved. So doing color vision is quite important. Um, you all have visual field machines in your offices, but back in the day when I was training, we didn't always have access to it straight away. So you could pick up central scotomas by just doing a visual field test with a red pin. So, presence of central scotoma and peripheral visual field defects are quite difficult to pick up unless they're very obvious. But as I said, most of you have access to a 24-2 or a 32 visual field machines. And actually for neuro, 32 is better than 24-2. So visual field assessment is quite important. And then how the visual field occurs, in glaucoma, for example, it doesn't respect the horizontal or the vertical meridian, but in a lot of neurological disorders like in infarctions and compressions, you do have this vertical and horizontal meridian respect when it comes to the visual field defect. And then, of course, if the eye is red, that might make you think of inflammatory causes. Flashing lights you could get in optic neuritis. And this other phenomenon, UTOF phenomenon, which tends to happen in demyelination, where the vision decreases with increasing in body temperature. So generally, you could see a wide range of symptoms that might present to you from nothing to kind of quite profound vision loss. And you could pretty much do most of these in your clinic. So if you've got somebody that you're worried about optic nerve damage, we would want to know vision for sure. We really want to do color vision, so make sure you get that Ishihara out. You should be able to look at the back of the eye and describe your clinical findings. You all have OCT, so optic nerve OCT is quite helpful. You can often see retinal nerve fiber layer edema on optic disc OCT. And again, as I mentioned, visual fields. Things you may not, obviously, pupil examination goes without saying. Things you may not have access to is an ultrasound. So we use that to pick up drusen maybe in the back of the eye. You can see the picture down here, these kind of white reflective stuff, that's fundus autofluorescence, again, something that we have access to in the hospital. Obviously, neuroimaging in form of an MRI, and finally, electrodiagnostics. So actually, if you look at kind of all these various tests I've put up here, majority you can do in the clinic. And I've got eye movements here, and those of you who are kind of thinking, well, optic nerve has nothing to do with eye movement. Well, any condition that might affect multiple cranial nerves, including the optic nerve, might affect your third, fourth, or sixth nerve as well. So eye movements is another important examination. So we would certainly expect a basic set of findings before referral. Now, optic nerve pathways, as you know, optic nerves crossing the chiasm, and the nasal fibers and the temporal ones continue. So any kind of lesion in one optic nerve or the disc will give you a monocular visual field defect. If the lesion is at the chiasm, then you will have it in both eyes. Often it's a bitemporal visual field defect. And then anything beyond that in the optic tract or kind of visual cortex, you will have, again, the defect in both eyes. And this is where you kind of talk about congruous and incongruous visual field defects, where, the further back, so the further the lesion is towards the visual cortex, the more congruous it gets, i.e., it looks kind of quite similar in both. So you could kind of figure out where the lesion might be. But just to kind of show you that a third of your optic nerve serves the central 5 degrees. So most of the nerve fibers that are kind of that go through the optic disc manage the 5 degrees, and then the other 2/3 is for peripheral vision. And you haven't just got ganglion cell layer, you've got oligodendrocyte, microglia, astrocytes, and these are kind of supporting cells, which we all know too well can become cancerous in time. So normal disc can look variable. So sometimes you can just get one like here, which is like a small dimple-like central cup. This kind of, hopefully, most of you would pass that as normal. Sometimes you might have the cup a bit more deep and punched out, or you might see a temporal slope. So you can appreciate that in all these, the retinal nerve layer is kind of quite pink and yellow. So there's no pallor to the optic nerve, and there's no swelling. Clinically, swelling can be distinguished by looking at the blood vessels going into the disc. So if you have got optic disc swelling and edema, then the blood vessels, the appearance can be quite blunted. So if the condition is only in one eye, you can kind of compare to two eyes together and use one as control. But of course, if you've got very subtle swelling in both eyes, it can be difficult to distinguish. And again, this is where your disc OCT comes in, because you can pick up really subtle swelling anyway. So again, you all know this cup-disc ratio can be horizontal or vertical, normally around 0.3 or 0.4. But don't forget, 2% of patients might have zero point 0.7 or more, and that can be what we call physiological cupping or a large cup. What's often abnormal is if you have asymmetry between the eyes. If there's more than zero point 0.2 asymmetry, then that is suspicious. But look at the new retinal rim, between the two cups, and that should look healthy, kind of orangey pinky type color. So that's how you would explain it. And we're going to concentrate on this swelling. So you could just see the top picture there is very clear swelling, this almost like champagne cork kind of type appearance. You can see nerve fibrillary hemorrhages. You can see the blood vessels are having to go up into the nerve. And then the middle picture is kind of optic atrophy, which often ensures after the disc because you've kind of got rid of the problem, and you get atrophy and the nerves kind of died at that point. And then optociliary shunts, which are essentially retinochoroidal shunts, different to the shunts that you would get from a central retinal vein occlusion. Those are generally capillary dilations, whereas optociliary shunts are kind of collaterals that happen between the retinal and the choroid system. And often you get the optociliary shunts as a result of strangulation of the optic nerve from optic nerve sheath meningioma or gliomas. So those are kind of the various appearances and various ways that you could describe an abnormal disc. So if a disc is swollen, we used to remember a surgical sieve. So think about infection, inflammation, demyelination, vascular causes. And really what you need to do is look at the pattern. We can all wheel off 50,000 different causes, but you've got to look at the patient in front of you. So often your patient might come to you with an existing problem. So that's why it's so important to ask them about previous medical history. They say, oh, I've got sarcoid, I've been diagnosed with lupus, or, I have MS. And then you see the optic nerve swollen, that can help you. Or if they've been diagnosed with any kind of infections, or they've recently been vaccinated or had a viral illness, that can all help you figure out the cause. So you wouldn't want to diagnose optic neuritis in a man in his 60s or 70s because it's just very unusual at that age range. Conversely, you don't want to think about a vascular cause in a fit 24-year-old or a 25-year-old because they don't have kind of, they shouldn't have issues with the vascular system. So you've got to think, although you've got this kind of system in your head of infection, inflammation, vascular demyelination, compression, all that is in your head. You've got to look at your patient and you've got to relate it to the patient in front of you. And often, we don't know what the cause is until we've done the other tests. So you can kind of have a differential diagnosis and you do your visual field defect, for example. So if you've done your visual fields and you see that the visual field is, for example, in this picture, clearly not respecting the vertical meridian, so it goes across, but it does respect the horizontal meridian, then you think it's a sectoral optic nerve problem. So you think vascular or maybe optic neuritis or something like that. If, like down here, it's kind of non-specific, then that will point to certain other causes. But generally, demyelination, which might be an isolated optic neuritis, happens in younger patients, often female, 20 to 50. It might be their only episode. They might never get it again. And that's an isolated optic neuritis. And most of the time, actually, we may not scan if the eye heals the way it does. So, you've got painful eye movement, vision goes, and then after 6 weeks, it comes right back up. And if it follows that pathway as an isolated, you could just not investigate. If it happens again, you must investigate. So if it's recurring or it's recurred twice, then you're thinking that this is maybe multiple sclerosis, which is causing, optic neuritis on a couple of occasions. And um, you know, again, what's typical with optic neuritis is that profound vision loss that you get after kind of painful eye movements. They don't always have to have poor vision. So sometimes, the vision could be around 624, but it could be as bad as perception of light. So um, it can be quite scary, especially if it affects both eyes. Again, we don't tend to do anything, but if it does affect both eyes, intravenous steroids can help recovery. But if it's in one eye and is following a course, then we don't often tend to treat. Apparently, oral steroids can make things worse. So it's you've got to be careful what you treat them with. Color vision is very important, often very abnormal in unilateral optic neuritis and RAPD, of course. So relative apparent pupillary defect if one eye is affected. That is also important. Prognosis is normally quite good. Most patients will regain vision. And hopefully, if that's a one-off, then that's it. But if it's recurring, then it's part of a chronic relapse remitting type issue, or it might be progressively worse and often can cause blindness, especially if it's as part of a wider neurological problem like multiple sclerosis. So with demyelination, think young patient, um, pain on eye movements preceding vision loss, it should recover after a few weeks. If it falls outside of that, then it's atypical optic neuritis and needs urgent investigation in form of blood and other things. So I had a lady when I was a senior house officer at King's. She came in, young patient, typical optic neuritis, and then 2 weeks later, she came in and had ophthalmoplegia. So that obviously wouldn't go with your typical, and she had third, fourth, sixth, then she had facial nerve palsy, admitted her quickly, and she had basically meningitis affecting the basal skull, and it was secondary to TB. So it's a very, very unusual condition. But the point is that, it involved multiple cranial nerves, so you knew something else was going on. And luckily at King's we had neuro, and it was all picked up. Um, okay, and then you've got this rather unusual. I've not really seen it post-viral infections, so following mumps, rubella, chickenpox. Thankfully, these are rare. Although some of these conditions are on the rise because people are not vaccinating their kids because they're still worried that there's this link to autism, and we are getting more mumps and rubella, but thankfully not seen often. It spontaneously resolves, but you might actually need IV steroids. Kind of going on further, kind of infectious type of optic neuritis. Again, it'd be unusual not to have anything else. So you might have Bartonella, which you can get from cats. So those of you who have cats, think make sure you're not getting bitten. So cat scratch disease. Then optic disc swelling normally is associated with a macular exudative scar, which I'll come to in a minute. But you can get lymphadenopathy, so you can get raised lymph nodes. So there'll be other systemic issues going on. You might have a skin rash, like you can see here with syphilis. If you're getting it at the palms of your hands and feet, that's secondary syphilis. And often, you might then get optic neuritis or optic nerve swelling involvement with that. Those of you who've ever gone to New Forest should watch out for ticks. So you can get Lyme disease. Lyme disease is kind of quite common if you get bitten by these ticks. But again, rash, you'll be unwell, you have lymph nodes, and of course, you can get quite a bad uveitis in the eye. So there'll be, as I said, there'll be other things that will be going on. So when you're looking at them and they've got systemic issues, you're thinking, could this be an infection? Of course, anyone with shingles, I mean, I've shown you a dermatome, which is not near the eye, but if once you've got a viral infection, it can stay, well, it will stay in you forever. So at times of stress or periods of immunosuppression, the virus can attack it and might present with just uveitis or an optic neuritis type picture. But often there is inflammation in the eye or retinal involvement. So you've got to think about the whole picture. That's the thing here. So here on the left, I've got a picture of a patient, which hopefully you will appreciate. You've got lesions on the iris. The pupil looks as if there's been inflammation. So there's posterior synechia. And this is what you kind of tend to get neurosarcoid. So often these patients already have been diagnosed with sarcoidosis. So you know kind of what you're looking at. Neurosarcoid can look very similar to MS actually. So the only difference is sarcoid affects the choroid and MS doesn't. So that's often quite a good way of distinguishing the two. And then I don't know, some of you may have seen these pictures before. We call this phenomenon neuroretinitis, where you've got optic disc swelling and you get this star kind of at the macula. And that 25% idiopathics, we don't know what causes it, but you can see it quite commonly in patients with cat scratch disease, so Bartonella, but can occur with Lyme, mumps, and syphilis. By the way, if you're ever doing an exam, in general, I know I've said this before, and you're stuck for an answer, if you say syphilis, you're probably right. It can do absolutely everything. Syphilis and lymphoma, those two you won't go wrong. Now, so uh, well, you'd go wrong if you're the patient, but you know what I mean. So you've got vascular kind of causes here. This is one thing that we're going to kind of spend a little bit of time on. So the ophthalmic artery, which wraps itself around the optic nerve over here, gives a branch within the optic nerve. That's called the central retinal artery. And then you've got these ciliary vessels, posterior ciliary arteries that come around the optic nerve. This is why, if you have central retinal artery occlusion, the nerve is not swollen. But if the posterior ciliary arteries are affected, which is a completely different circulation, then you will get optic disc swelling. Okay, so please don't diagnose a patient with CRAO if the nerve is not swollen. And you can also get, some of you may have heard, a cilioretinal artery. So that's present in about, I think, 15 to 20% of patients, comes off the posterior ciliary artery and supplies the macula separately. And why it's important is in these patients is that if they tend to get a central retinal artery occlusion, then the macula is spared because the macula is supplied by this other part, which is part of the choroidal circulation. So the choroid does around the optic nerve and sometimes can do the macula, but the central retinal artery does everything else. So it's kind of important to know the difference of that and what supplies what. Now, this kind of patient, so what we call ION, ischemic optic neuropathy. Okay, so we got vascular cause. Okay, and if you say NAION, non-arteritic ischemic optic neuropathy, that means there's no inflammation in the blood vessels. You can often see these patients because if you look at the other eye, there's hardly any cup. So everything is very, very tight as it comes out of the optic disc. And that is called the disc at risk. It means it's a disc that doesn't have a cup. Everything's very tight. And you will notice this if you look at the unaffected disc. Happens to patients about 55 to 70. And of course, one thing that does increase your risk is vascular causes like high blood pressure, diabetes, high cholesterol, phospholipid, and antiphospholipid syndrome, collagen vascular disorders, and actually hypotension. So sometimes patients wake up in the morning with loss of vision, and that's because they've had massive drop in the blood pressure. And as a result of that, they get this kind of ischemic optic neuropathy. So the disc would be swollen because it's not your central retinal artery that's affected, it's the posterior cilaries that have blocked. And the patient will have a visual field defect. So if it's the top of the optic nerve, then they will have an inferior visual field defect, which you can see very clearly here. Swollen of the disc. Actually, that's not a good example. Sorry. So if you've got swelling of the superiorly, then you will have an inferior visual field defect. So the disc would be swollen superiorly. Okay. And what you've got to determine very quickly in these patients is if you've got a swollen disc, loss of vision, is there evidence of inflammation? So you would want to ask about headaches, pain, jaw claudication, tenderness in the scalp, all the things to make sure that you haven't got actually an arteritic phenomenon here, and it's non-arteritic. And often, these are painless. So they'll just wake up and say, "I can't see out of this eye," painless, and suddenly it happened quite suddenly. And often it's monocular. So um, just be aware that you've done a visual field and your color vision and all the other things. Okay. And of course, we send bloods because you need to make sure that there is no inflammation there. And prognosis is that 10% can have the other eye involved within 3 years, 15% over 5 years. So it is important to make sure that you have managed or optimized their cardiovascular system. Often, what we do is actually send the patient to the TIA clinic. It's brilliant. They normally tend to see the patients within 2 weeks. So they do an ECG, they'll do an echocardiogram, they do carotid ultrasound to make sure that everything is fine and there's no embolic phenomenon. Obviously, they run bloods for inflammatory markers to exclude GCA. And, unfortunately, there's no particular treatment. Sometimes I have seen some visual field gain because once the swelling resolves, then you will see what the damage is. So some visual field can come back, but often it doesn't. And then the management really is to manage the cardiovascular system. By the way, the rheumatology department really doesn't do or doesn't advise on biopsies anymore. It's quite a, if you've ever seen one, it's kind of quite a traumatic thing for patients. So what they do now is an ultrasound. So the ultrasound is quite a good indicator whether the patient has occlusion or GCA or not. They only kind of tend to then biopsy if your bloods or ultrasound is not or is not conclusive and you need conclusive evidence. And the reason for that is because if you're going to treat somebody as GCA, they'd be on steroids for up to 18 months to 2 years. And that can cause diabetes, hypertension, osteoporosis, all sorts. So you need to make sure that you've got the diagnosis right before you organize it. This is one thing that I kind of want to hammer in, make sure you don't forget. You don't want to miss this patient. So this patient will have sudden loss of vision, painful, swollen disc. Often the disc is kind of quite pale, and you can also often see or may see a cotton wool spot around the disc. So swollen disc and a cotton wool spot, you think GCA. Okay. Now, if there's no cotton wool spot, that doesn't mean it's not GCA, but anyone with a swollen disc and pain, you think GCA. And the reason why it's important is because if you've ever picked up a medical legal book, you will see that a lot of these patients end up blind in both eyes if they're not treated. So the risk to the other eye can be as high as 75%. And they may not have other symptoms. So they might come and say, oh, they've got a headache, which is often temporal or one side. But actually, what's quite a distinctive feature is jaw claudication. So jaw claudication is basically as they chew their food, they have pain. And that's because the masseter, which is a muscle in your jaw, will kind of, oh, my battery, I've got 10%. The masseter in the jaw will often, sorry, will kind of cause issues as you're chewing, and that ischemia as you're chewing can cause issues. So that's very important to know. And then you might have other cranial nerve involvement, so third, fourth, or sixth involvement because GCA can affect multiple cranial nerves. But apart from the fact that you can have blindness in both eyes without immediate starting of steroids, you can also cause stroke. It can also cause a stroke or a heart attack because it's inflammation of all the blood vessels. So it is very, very important to send these patients immediately to the hospital so that they can have treatment and we can manage them. And yeah, I kind of mentioned the whole pale swollen disc and the chalky white thing. So if I and treatment is often very high dose steroids. So we need to kind of give them steroids IV. So they have IV steroids. Normally, if they've got kind of GCA symptoms and there's no disc swelling, so if I kind of say that your patient has headache, jaw claudication, maybe the inflammatory markers are high, but there is no visual symptoms or the back of the eye is not affected, you can start oral steroids. But if there is any involvement of the optic disc or the eye itself through occlusions, vascular occlusions or cranial nerve palsy, they need admission and IV steroids. And as I said, they're often on steroids for a very long time. So you need to make sure you've got the diagnosis right. And sometimes you might even need second line anti-inflammatories to try and get them off steroids. So here's a picture of what I was saying, a swollen disc and a cotton wool spot here. Again, here, swollen disc and a cotton wool spot here. This patient has a swollen disc, and actually they have a branch retinal artery occlusion inferiorly. So in this kind of scenario, as I said, urgent, they need to there and then come to A&E. We need to start them on steroids. And as I said, if untreated, the other eye can often get involved. And these patients are at risk of a heart attack and strokes too. This is kind of another vascular thing that's interesting. So you can get diabetic papillopathy. I see a lot of diabetic patients, but there are very few that I see who have papillopathy. So often this is like a swollen disc, as you can see here, looks kind of quite scary, really swollen, lots of vasculature. You almost think loads of NV disease. In fact, this is not NV disease. They're just like telangiectasia-like lesions, but the vision is often quite good and it tends to spontaneously get better. You might get visual field defect in form of scotoma or a constriction, but the prognosis is quite good. So that's in a patient with type 1 or type 2 diabetes. Toxic and drug induced, this is very important to ask if they smoke or they drink. So those of you who smoke, beware. So tobacco, alcohol, amblyopia is common and often it's because of vitamin deficiencies, in particular B12 and folate. You tend to get central scotomas, so centrocecal scotomas. But they will tell you, oh, smoke 40 a day or, drink a bottle of wine. A night, and that can obviously have an effect on your optic nerves in time. And then there are certain drugs like anti-TB drugs, antiarrhythmic drugs like amiodarone, ethambutol, and things like that that can affect the nerves. So that will be clear in the history, but just to kind of be aware of that. One thing that obviously scares a lot of people is, papilledema. So papilledema is a term we use in patients who have raised intracranial pressure. And this is often secondary to, papilledema, yeah, from a raised intracranial pressure. So it doesn't always mean that there is a kind of occlusion or a mass effect. It might just be that the CSF is not getting absorbed. So that's an idiopathic intracranial hypertension where your neuroimaging is normal. But obviously you want to exclude a space occupying lesion. And symptoms are kind of quite different. So often you have headache, which is worse in the morning. So it kind of wakes you up, okay? And that's worse if you're bending down or if you're coughing. Depending on where the lesion is, you might have other neurological symptoms. So if it's, God forbid, you got a brain tumor near your motor, you might kind of feel your arms or leg on on the opposite side is not moving. You might get paresthesia if it's in the sensory side, speech impediment, or visual cortex issues, depending on where it is. So you do want to ask if there are any other neurological symptoms. And so you've got the headaches in the morning, worse in bending down, worse if you're coughing and vomiting. So that's quite important. And within the vision, what happens is they've obviously got swollen optic nerves. The vision can be quite good. So a lot of patients might have 6/6 vision or 6/9 vision. But what they do get is this visual obscuration. So they'll tell you that the vision goes and then comes back again. Not quite like a stroke type effect where you've got amaurosis curtain-like effect coming down. Just vision obscures and goes down. So if you've got anyone like that, obviously we need to urgently neuroimage them and basically try and see what's happening. And this is kind of like your, if you see somebody with an, you can all kind of diagnose it when it's at the established or the long-standing part, where in the long-standing part you've got this champagne cork type appearance, but no real hemorrhages. There in the kind of post-immediate part, you can see these hemorrhages around the optic nerves. But when it's kind of just slightly raised, it can be quite difficult. And I think a lot of people just panic and start sending patients at that point. But if you're worried, you've got to send it. So, if they got, especially if they got symptoms of headache and, raised ICP symptoms, and you think the nerve looks a little bit raised, then you do need to kind of look into that. Now, the other thing to look for is spontaneous venous pulsation. So if you've got SVP, that's a really reassuring sign because if the disc is swollen, the SVP goes. Now, 20% of patients don't have an SVP. So sometimes you can induce an SVP by gentle pressure on the eyeball. So kind of remember that. Right, okay, we're going to come to quiz. I'm going to actually, I'm just going to put my stupid computer on the charger so I don't lose you guys, and then we can have a chat on the quiz. Right. Location. Ian, how are we doing? Are you still with us or you
I'm
asleep?
I'm still with you. Yeah, I'm ready for the quiz.
Good. Let me just connect it. Sorry. I obviously need to change my computer because I had it fully charged 2 minutes ago and it's gone. So sorry.
Right,
Oh my God.
right. And the
How
poll is
bloody
still going.
embarrassing is that? If anything, I knew I should have. So can everybody see? Yeah, keep drinking that wine in while I'm bloody stressed. Can you see it?
I can see it. Yes, sorry. Yes, we can
Okay,
see
fine.
it.
All right. Okay,
And we can
fine.
see the poll.
Okay, we are back on. All right. So I'm really sorry, guys. I can't apologize enough. Right. What's the most likely diagnosis here? So can you put the questions up? Is this
The,
disc
the, the
papilledema?
questions are up. Quiz one. This is the first one. They've been up for 10 minutes.
Okay. So do we have the response?
Yes, I can end poll and
Yeah.
show results now.
Okay, dystrophin 80%, glaucoma to papilledema. Okay, glaucoma. Okay, good. So majority of you were correct. So the reason this is disc drusen, so I can see why some of you say papilledema because the disc is swollen. However, if you look at the nerve, you can see superiorly these drusenoid kind of yellow lesions that are breaking through. And that's what's going to make it disc drusen. Also, if you look at the blood vessels, you have this very abnormal division of blood vessels after they're coming through the disc. So normally you have your supratemporal, supranasal, infratemporal, infranasal blood vessels, whereas in disc drusen, you've got either trifurcation, either just three trunks that divide, or you've got very abnormal looking division. So often, if it looks like this, then you know what it is really because you can see kind of the drusen being present. But if you can't see that, then you've got to assume that it might be papilledema. So we will do an ultrasound, which will show the drusen. Sometimes, you or a fundus autofluorescence. You may have remembered I showed you the picture of a fundus autofluorescence earlier. That was this drusen. So that will kind of often show this hyper-reflective material in the disc when you're examining.
Can
Okay,
I
so
just
this
ask,
is this reason.
sorry, Shark. Peter, I've had messages people saying they can't see the images. Can people comment in the Q&A box? Can you see the image? Are you showing your screen, Shar?
Your screen sharing is what I've got. Yeah.
Yeah, a few people mentioned they can't see the images, but hopefully, I think that was when you may have been off the offline.
I
But,
think.
yeah, people are saying, yeah, I can see images seen. Sorry, yeah, right.
Okay, right. All right. So the reason it's not glaucomatous cupping is because there's no cup-disc ratio. I think I've explained why it's not papilledema, although I could see why people think that. So if you didn't have these kind of yellow lesions, then you could see it, and it's definitely not a cloboma. All right, question two. So you've got a disc here. I've got some kind of black pigmentation in the retina. Is this an optic disc pit? Is this optic disc atrophy? Is it glaucomatous cupping, or is it a tilted optic disc? So um, if you put up the poll,
My bear with launch now.
this question was given to me by one of my friends, Dr. Caro. So the thing goes to them. Anyway, okay. So disc pit, atrophy, glaucomatous cupping, or a tilt. So let's have the okay. So you got 10%. Yeah, again, majority rule. Well done. So it is an optic disc tilt. So optic disc tilt is when the optic nerve, you can close it now, the optic nerve enters the globe at an angle. And actually, what you can often see when that happens is inferior kind of temporally, you can see this choroidal retinal thinning that happens as the tilt comes in, and they do get visual field defects, but it doesn't tend to look very glaucomatous, and it doesn't respect the horizontal or vertical meridian. It's kind of quite an odd looking visual field defect. With an optic nerve pit or optic disc pit, you can normally see the kind of pit as you're looking at it. Clearly not a pit here. Optic disc atrophy or glaucomatous cupping. If you look, the neuroretinal rim is fairly well maintained. So you can see inferior nasal, sorry, superior nasal and inferior. I grant that temporally it looks a bit kind of not quite right, but that's because of the tilt. But also, if you look, this area of the retina looks different to the top bit. So with an optic, this tilt, often look to see if you've got that chorioretinal thinning. Okay, right. Now, this is, don't adjust your glasses. The picture is not great. So you've got a patient here who has got what you see. Is this neuroretinitis? Is it diabetic retinopathy? Is it grade 3 hypertensive retinopathy, or is it a central retinal vein occlusion? Right, so neuroretinitis, diabetic neuroretinopathy, grade 3 hypertensive retinopathy, or central retinal vein occlusion. Right, okay, so we've got a split. We've got a split. So, okay. Um, right, so I mean, it could look like all of those, but there is one particular diagnosis which it is. So let me just kind of count these off one by one. Central retinal vein occlusion um, is doesn't tend to give you exudates like that. Often with CRVO, you get the venous system, which is becomes tortuous. You get a lot more hemorrhages. Okay, you don't tend to get much in the way of exudates. All right, and diabetic retinopathy, you can obviously get the exudation and the hemorrhages, but you don't really get the disc swelling that you have here. And it's quite unusual to have that many cotton wool spots. So really, the differential here is between um, grade 3 hypertensive retinopathy or neuroretinitis. Now, if I had written malignant hypertension, i.e., grade 4 hypertensive retinopathy, you would be right. So, grade 4 hypertensive retinopathy is when you have got disc swelling and exudation and loads of cotton wool spots, but this is really neuroretinitis. So remember, a swollen disc and a macular star like that is neuroretinitis. And there are certain conditions that can do that. If you remember, cat scratch disease, so idiopathic in 25%, but the other kind of 75% infections like cat scratch disease, Lyme, and our usual friend syphilis. So this is neuroretinitis. Hypertensive retinopathy, starts with AV nipping, silver wiring, things like that. Then as it progresses, you can start getting other things. But malignant hypertension, massive hypertension, that's when the disc swelling comes in. So that's grade 4 hypertensive retinopathy, when you can get the swelling and the cotton wool spots. So the correct answer was neuroretinitis. I think that's the first time we've ever done a quiz where the minority have got the right answer. So that's the first time ever, I think. Normally everybody gets it right, or pretty much right. So remember, neuroretinitis is swollen disc, macular star. Okay, so macular star and swollen disc is neuroretinitis. Okay, fine. Most likely diagnosis here. So is this an arteritic ischemic optic neuropathy, optic nerve melanocytosis, macro cotton wool spot, or leukemic infiltration? Okay, so let's see what we've got. Okay, so all right, so another one that's interesting, even split, but I think the majority have got it wrong. Okay, fine. So macro cotton wool spot doesn't exist. I just made that up. So there's no such thing as a macro cotton wool spot. Cotton wool spots are infarction or mini infarctions of the retinal nerve fiber layer. They're generally quite small. There are certain conditions where you can get confluent cotton wool spots. That's within the retina, not within the nerve itself. You can see that nerve looks pretty kind of abnormal, can't you? So it's not going to be an AION because you can't. It looks as if there's something else that's infiltrating through the nerve. Within the AION, you can get disc swelling and the nerve can look slightly big, but not like that. I mean, that looks like a four disc diameter lesion by three. So that really is leukemic infiltration. And any kind of infiltrative process like sarcoid, leukemia, things like that can make the nerve look really abnormal. In fact, you can't really distinguish where the nerve is. Even in papilledema, we say that there is, you can't see the edge or something like that. You can still see where the nerve is. But in patients with leukemic infiltration and things like that, you can't. So that's the right answer. Optic nerve melanocytosis tends to. Let me just close that for you. Ian, can you close the thing? It tends to you tend to see pigmentation. So I will show you a picture of that. If I go to the beginning of so you know what that looks like. So you just see pigmentation there. That's the kind of, so you can still see some of the disc, but you can just see melanocytosis occurring there. Okay, so it looks quite different. And in case of swelling, as I was saying here, you can kind of see where the disc is, but obviously it's not expanded 4 times its size. So when you see something very weird and very abnormal like that, think infiltration. Right, where were we with the quiz? Okay, here. What's the most likely diagnosis here? Is this glaucoma, morning glory syndrome, optic disc pit, or optic disc drusen? So this is a very typical appearance of this particular condition. Yes, 80% right. Okay, excellent. So let's just go through this now. So you can clearly see that the optic nerve here, actually here, looks very abnormal. So that's a pit, okay? And what the reason it's not drusen is because the disc is not swollen, okay? So optic disc drusen tends to give you a swollen disc. You might also see the drusen at the surface of the optic nerve, but not always, but clearly you can't see that. It's not glaucoma because it would be a very strange looking cupping. So you could just see that cupping tends to be thinning of the, inferior or superior nerve fiber layer. This is kind of a very asymmetric kind of issue here. Morning glory syndrome tends to involve the whole disc, and the disc tends to look a lot bigger. Actually, you can still see the edge of it, but it looks a lot bigger. So this is optic disc pit, and patients with optic disc pit can get subretinal fluid, which can expand towards the macula and cause visual symptoms. And often the treatment for that is vitrectomy and gas to put the fluid back on, to push the fluid back. I've just put this up because this is my take-home message. You'll be pleased to know we're coming towards an end. So if you see a disc like that, you can just see a very swollen disc, chalky white, okay, with a cotton wool spot, thick GCA. This is very, very typical of a patient who has GCA, and they've often lost vision in this eye, but without steroids, they're at high risk of a stroke or a heart attack. So you could save their life by referring them in. And thank you. And once again, I am very sorry about the interruption caused by my stupid computer. Anyway, that gave you a bit of a heart attack, didn't it, Ian?
Not half. What just happened there? That was a bit of a
Well,
train.
the computer said 10%, and then I thought, oh, I must get up and put it on charge. And then before I knew it, it went. But I think we lost 5 or 6 people, sorry, not patients. The rest are
So
here.
I think we recovered it well. It just amazes me that us lower sort of mortals have better computers than what you seem to have, really. It's sort of you need to buy a decent computer with your salary.
Yeah, if I wasn't buying you so many coffees, I would.
So I've gone through the comments, and there's so many people who have said, yes, I could see the image. No, I can't see the
Yeah.
image. So thank you for bearing with us. Do apologise about that with the loss of connection, and then I think some of the polls didn't show and things. But please bear with us. This is not our normal standard of webinar, is it, Shah?
No.
If it is, I'm going to sort of quit. We have got some questions. Uh,
Okay.
Mohammed Channing, OCTA would be a good topic. Oh, that's for
Okay. Yeah, actually.
future talks.
Yeah, I
So
could
why
do.
is cataract surgery a risk for non-arthritic ischemic optic neuropathy?
That's a very good question. And that's because it is associated. So you can get non-ischemic arteritic optic neuropathy following cataract surgery. Uh, I would imagine probably due to kind of changes in eye pressure as you're having surgery. But it has been described. And in fact, I remember when I was examining at the Royal College, we had given that very scenario to the candidates. So it can happen. The actual causes are kind of fairly poorly understood, but it might be something to do with changes in eye pressure as you're doing cataract surgery.
Mhm.
Often, a lot of NAION is due to hypotension. So the other thing is if the patient has been on the kind of sedation or GA and the BP is dropped, then that can cause infarction as well.
Mhm. Thank you very much. So, folks, should you do a graft if needs cataract surgery, or just do cataract surgery and see what happens?
Fuchs, that's coming to the front of the eye. Okay, fine. So the question is, should you do so Fuchs where you've got endothelial cell dysfunction, numbers are low. We would do the cataract, but we use something called the soft shell technique. So we've got two different types of viscoelastics that we use in order to protect the endothelium and do the cataract. What you
Mhm.
want to do is to use as little energy as possible to remove the lens. There are not many people now do the triple procedure. Obviously, if you've got a cornea that's very swollen and you can't, you've got not good vision of the cataract, then in that scenario, they might do what we call a triple procedure, where they do the cataract and the corneograph at the same time. But I would say we majority of patients with Fuchs do very well with cataract surgery. The main thing is have a low threshold for referring them on, because if they have got Fuchs, you will make it worse. And if the cataract is mild, then the damage will be limited. Why are you smiling or smirking?
I missed the last bit of that. It was like, oh, is that on topic for another webinar?
Oh,
Oh, sorry. So,
oh God.
sorry. Yeah, I know
How
it's.
many glasses of wine have you had, Ian?
I've not had enough. That was amazing, Dr.
I've
Kashani.
stressed you out enough. Okay, so Fuchs,
So,
sorry,
with
I thought that was being.
OCT and a swollen disc, what signs should you look out for on OCT?
On OCT for a swollen disc. So actually, it's pretty much kind of a swollen retinal nerve fiber layer. So if you look at your OCT scans, you will see kind of green, yellow, or red. Yes. So green
Yeah.
being normal, yellow being kind of borderline, red being thinned. Often in patients with swollen disc, it will be white because it's off the scale. And that's where you see it. But I don't, I mean, OCTA is being, not OCTA, OCT is being used to look at disc monitoring, but taking color pictures is often a better indicator of how the swelling is resolving. So that's what you're looking for. Essentially, you're looking to see the thickness of the retinal nerve fiber layer because you've got retinal nerve fiber layer edema. What I was going to say is, if you think somebody has a swollen disc, you're not 100% sure, really look to see if you can see spontaneous venous pulsations. Because if you've got SVP, that's a really reassuring sign. And sometimes I said 20 to 30% of patients don't have SVP. So just very gentle pressure on the eyeball just for a few seconds and let go, and then you might be able to see the SVP again.
Thank you. Could you please could you classify with the hypertensive retinopathy question, as I believe that G4 can have a macular star and papilledema.
Yeah, it can. That's why I said it's not. That's why I said that was G3. So hypertensive grade 3 doesn't have the swollen disc and the exudate. Apologies if I didn't make that clear. So if I had written G4 or malignant hypertension, then that picture could have fit with that, which is why I put grade 3 hypertensive retinopathy, not grade 4.
So, just trying to check which is relevant. Don't worry about the IT issues. Really good talk. Are you seeing
Did you just
cases?
make that up?
No. Non-arthritic ischemic optic neuropathy due to weight loss injections. That's an interesting one.
Yep. So it's known, it's becoming clear now that some of these weight loss injections are associated with NAION, Mounjaro, Ozempic. I'm not sure about the exact mechanics of it, but and I wouldn't want to guess without looking into it. I will look into it and see if there's anything that's been done. So, but there's definitely an association. I mean, it's not, if you think a lot of so many patients are on it now, so many people are on it. So, it's only some people are going to get it. So, is it an association or is it the fact that when you start something new, anything that happens gets reported? So, you've got to kind of see whether it's a chance finding or whether there's a true correlation between the two.
Cool. So, two patients, both male, one teenager, one late 30s,
Where are
no
we going with this?
symptoms, unilateral disc swelling, sent to a hospitalized service, monitored, then discharged. Obvious normal discs, then disc swelling, then all back to normal. No treatment. What caused it?
Hmm?
I don't know
What?
about that one. Two patients, one teenager, one late 30s, no symptoms, unilateral disc swelling, sent to HES, monitored, then discharged.
So the question is whether there was true disc swelling or not. I mean, if you've got disc swelling, there must be a reason. Disc swelling is never normal. So, if it's unilateral, then could it be just drusen, for example? I said with drusen, if it's on the surface of the optic nerve head, it's easy to see. If it's buried, you can see the swollen disc without the other typical features, which is where you do a B scan. So whether it was kind of dystrusion, and by the way, with dystrusion you can get visual field defects, which are often stable. So and there's nothing you can do about it anyway. So whether it was that or it looked like a swollen disc, but in fact it doesn't. So normally our strategy would be to do bloods, B scan, neuroimaging to make sure there's no space occupying lesion. If they're at risk group, then they might need a lumbar puncture to ensure that the CSF pressure is not high for idiopathic intracranial hypertension.
Is it possible for papilledema to be congenital or normal for someone?
No. So papilledema is the term we use for a swollen disc due to raised intracranial pressure. So otherwise, you shouldn't call it papilledema. You should call it a swollen disc. So papilledema means raised ICP. It's quite normal for that to be due to raised CSF pressure, or God forbid, a space occupying lesion, but it's not a normal finding. No. I mean, could it be congenital if the child's born with kind of obstructions in the in the way the CSF is absorbed, or they've got some sort of tumor, then obviously they'll have papilledema, but it's not a normal finding.
So do all disc OCT in the white present a risk even though the disc looks okay?
No, yeah, so that's a very good question. Don't forget that the green, yellow, and the red is based on a normative database, and there's not of that many patients. So just because it's in the white, it doesn't mean it's abnormal. You've got to look at the disc, look at symptoms, look at the nerve, look for spontaneous venous pulsation, look to see if there is any blunting of the of the blood vessels that are going in. So um, if you've got a swollen disc, then it's fair to say you would expect the retinal nerve fiber layer to be oedematous and you see the white on the disc OCT, but the reverse is not true.
Cool.
You've got to look at the clinical picture.
So this is what from one of our hospital optometrists. I had a bilateral papilledema patient today in RAC. 35 years old. What could the main cause be? And they were male.
So I would want to know the weight, BMI, of the patient. I'd want to know if they're taking any medication, especially
acne medication because that can cause IIH. Okay. I would want to ask them about symptoms of raised ICP, so headache, nausea, vomiting. So you'd want, so basically, you've got bilateral papilledema, you're mainly thinking space occupying lesion or idiopathic intracranial hypertension. If the patient is well, it is very unlikely for it to be due to a thrombotic effect like cavernous sinus thrombosis because that tends to be unilateral. That's another important one, guys. If you've got a young patient who might be who might be dehydrated, so these ones who exercise quite a lot, or a young patient on the pill, unilateral, you need to kind of think about cavernous sinus thrombosis, which can be fatal. So, but they will be unwell with other symptoms like headache. So I think bilateral, you're thinking, space occupying lesion or idiopathic intracranial hypertension. So that patient needs urgent neuroimaging and referral to the medics. If you haven't done it, please do it.
Thank you. I'll probably just do a couple more because of the time. But if demyelinated nerve fiber closer to the disc seen as first time finding in clinic with headaches as a symptom, or if without any symptoms, does it need any investigation further?
If it's demyelination,
Yeah, but
well, I
no
mean,
symptoms.
so I presume that kind of doesn't make sense. So if you're saying swollen disc, typical optic neuritis, no other symptoms, it follows a typical pattern, i.e., probably a female, young, no other neurological symptoms, only their second nerve is affected, painful eye movements, vision goes down. You could observe that without doing anything else. Then the vision comes back. That's actually quite important because if you do a scan, it might show other lesions, and then you might be then thinking, is this MS or whatever, and that could affect the life insurance and all sorts of things. So a typical optic neuritis, as I said, should get better after 6 weeks without any other cranial nerve involvement and without with the vision improving. So if it's following that course, you don't need to do anything if it's the first time. But if it's you got other cranial nerve kind of involvement or it doesn't get better, then that needs neurological referral and full investigation. Because not everything's going to be MS, right? You might have sarcoid, you might have things that actually you can treat. So even MS, you can treat with interferon B and stuff like that. So an isolated optic neuritis on its own that follows the normal recovery is fine, but anything else needs referral.
I'm not going to go through them anymore, but hi, would you be able to please pass the slides out to us? Because there was a lot of
It'd be on
information.
the thing you want it. It'd be on the YouTube channel.
Suggestions for future webinars. Can the speaker please do a beginner's course for speaking on, oh, sorry, I'm misreading that. OCT for complete beginners who haven't had access to OCT in practice before. You've done that before, haven't you? Can you do that again?
Yeah, I can do an OCT one. Just let me know what you want. That's fine.
Cool. Right. The last question I'm going to pose, because I know it's going on. Is
Get
it
a new
possible
battery on
that
the car. Yeah. Get a new battery
is
for your
it
computer.
possible? Can I finish?
Yeah, sorry.
Right. Is it possible that traction from vitreous at the optic nerve head can appear as swelling?
Yes, 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 yes. So actually, it's not so much optic disc swelling, but what you can get is this schisis by the optic nerve, almost looks like subretinal fluid. So the differential diagnosis is a peripapillary choroidal vascular membrane or vitreomacular traction at the disc. And if it normally with traction, you tend to get the schisis within the retinal layers rather than it appearing as subretinal fluid. So if there's no hemorrhaging, if the fluorescein, for example, is negative or OCTA is negative, then it is probably actually vitreomacular traction, and it can appear as swelling of the retina or fluid, if you like, but not swelling of the disc.
Ooh. Do you want to do any more questions, or are
I
you
don't
ready?
mind.
Um,
How many are here? 120. I'm sure they want to go, but you can maybe ask
Eve,
another one, and then I'll go.
one more.
Choose a good one, Ian.
So here we go. So it's a random one. If a patient asymptomatic, young, but with slightly blurred disc And even if we suspect a crowded disc, is it still urgent? Any tips to classify crowded disc over asymptomatic
So
papilledema?
um, if you see it in both eyes, then you need to refer. I think, look, at the end of the day, um, if you think somebody has a swollen disc, then it's always better to refer and be told it's not swollen than not to refer, and then you could be missing something. But a swollen disc, no, what would be quite useful for us though, is to include the vision, pupillary responses, eye movements. If you have the ability to do visual fields, and tell us why you think it's swollen. So is there SVP, for example? But if you're looking at this and going, oh, this doesn't look like, the optic nerve does look raised in one eye, they usually will have symptoms. But there are situations where really early disc swelling may be asymptomatic. So if you're not sure, just write that all down and we will have a look.
And do color vision.
Color vision, yeah. So you could do all that. So your referral letter could be that asymptomatic, everything's normal, but I think that this looks, the optic nerve head looks so. And look at the other eye. If it looks clearly different, then you have a case. If you're not sure and you think, this is probably normal, just invite them back after 2-3 weeks. Tell them if you get any symptoms come back, repeat all the tests again. What might be useful is a really good color picture and put it on the WhatsApp group, and then we can advise you. That might be better. But
Cool.
you want a really good color picture.
Cool.
And the
Thank you.
information that I just mentioned.
Cool. Thank you so much for your time, Mr. Kashani, and for
I'm really sorry about the
the
5
train crash and the heart pressure that you gave me. My blood pressure is going to go right. I'm going to have to go to hospital and get my eyes checked just to see if there's any.
Yeah, you probably got grade 4 hypertensive retinopathy.
So thank you very much for joining
That's
us
all right.
today,
Sorry,
everyone.
guys. Anyway, we got there at the end.
Yeah,
And thanks for sticking around.
I'll see about editing it to put it onto the YouTube channel. I say I've got some more webinars planned, so I'll be posting those on the group if I'm still sort of
Thank you.
up to it. The certificates I will get out next week because my IT expert is not here this weekend. She's gone away to visit a family, so yeah, she does all that, and I don't know how to do it. So certificates hopefully middle to end of next week. And thank you all very much for joining us. And yeah, I'm probably going to go and just have a glass of wine now after that train crash. Normally our webinars are very smooth and very good, but tonight was just like, yeah,
That's okay. We call it the beginning of the year nightmare, and then we'll be okay. That's fine.
we
Anyway,
survived.
thank you very much.
Thank you
All
very
right.
much, everybody. I'll see you all soon. Thank you. Take care.
Bye.
Bye-bye. Bye.